Welcome back, everybody. Very excited to transition to this next part of our meeting, our policy roundtable. Point of our policy roundtable is to have a discussion of how we ensure evidence-based policymaking around the introduction of this new therapy now that we've had the robust discussion on the evidence and on the value. So we are joined today by a fantastic group to help us talk through some of these important issues. We'll start by asking everyone to introduce themselves, and then we're going to dive in for what I hope will be a really lively and entertaining conversation. Let me first start by asking Todd to say hello again for those who might just be joining us at this point for this part of the meeting. And Todd, just to note, you've already done this, but again, for the record, if there's been any changes to your COIs, go ahead, Todd.
Yeah, hello, this is Todd Durham. I'm the Senior Vice President of Clinical and Outcomes Research at the Foundation Fighting Blindness. No changes to my conflict of interest statement.
Thank you so much, Todd. And Julie.
Julie Gritzmacher, Director of Patient Advocacy and Population Health at Prevent Blindness, and we do receive some nanoscope funding.
Appreciate you noting that. Thank you so much. Hemant, thanks for being here.
Thank you, Sarah. Hemant Hora, Vice President, Senior Medical Director at Point32 Health on the payer side, parent organization of Tufts Health Plan and Howard Pilgrim Healthcare. I'm an internist by training. Still work a little bit clinical part-time, but yes, I am full-time at Point32 Health. No issues with conflict of interest.
Fantastic. Thank you so much. Dr. Mahajan.
I am a professor of ophthalmology at Stanford University. I've been involved in a number of human gene therapy trials and studies, also from the basic science side. And I have a paid advisor to Nanoscope Therapeutics. I don't hold any equity in the company.
Thank you for that. Samar, thanks for being here.
Thank you, Sarah. Nice to meet you all. I'm Samar Mohanty, co-founder, president of Nanoscope Therapeutics. I'm a full-time employee of Nanoscope.
Thank you so much. Lindsay, welcome.
Hey, Sarah, and hello. So I'm Lindsay Ripplemeyer. I'm a senior director at Express Scripts, and my role right now is in supply chain finance, but I am a pharmacist by training.
And your disclosure is that you are an employee of Express Scripts. Thanks for being here, Lindsay. And Dr. Russell, you with us? Dr. Russell might have had to step away for a moment. So we will, his disclosures are here on the screen for the record. And then when he gets back, we'll be able to integrate him into the conversation. So I think we can take down that slide now. Thank you so much, team. So it's really my pleasure to be able to now reflect on what we heard today about the new therapy that might be approved sometime this year for treating retinitis pigmentosa. We're going to go through a couple of different categories of themes today. We're going to talk about health equity. We're going to start there in just a moment. We're going to reflect on the votes that we heard today on comparative clinical effectiveness and benefits beyond health. And then we're going to spend some time talking about coverage policies. And we're going to do that because at the end of the day, we will be, as a society, making some decisions about what those coverage policies say in terms of access to this therapy. And how can we make sure that those payer coverage policies are reflecting the best evidence or are staying true to the idea of getting affordable access for patients. We're going to also save some time to talk about future research needs. And so we have already touched on this a bit today. This is a orphan condition. This was a small trial. It might have raised more questions than it did answer those questions, and that's okay. What can we look forward to in a robust research enterprise to try to answer some of those questions? I'll tell everyone on the policy roundtable now. You get a final call to action at the end. You can start thinking about that now if you want. It can be something you wish was done differently. It can be telling somebody else in the ecosystem to do something. Nicely, of course, but you'll be able to close with sort of a final call to action and service again to this idea that we can have affordable access to this therapy. All right, let's start with health equity. Let's dive right in. One of the things that struck me as part of this review and in the conversation today is, and we saw the votes, we don't have any reason to believe that there's a big racial or ethnic issue in terms of distribution of the disease. However, your ability to adapt to this type of diagnosis can be a reflection of your existing privilege. If you have the means to purchase mobility aids, get a trained dog, have a family support system that's helpful, that can mean a very big difference in your quality of life and your ability to adapt to this diagnosis. So that means there are people who might be historically disadvantaged by the healthcare system who don't have that kind of advantage. Now, we can talk about this in the context of treatment for people with RP generally, also specifically about this therapy, and we're going to touch on that in terms of centers of excellence and affordability. We're going to get to that. But I'd love to start with Julie and Todd, because I'm sure you think about this a lot in your organizations and sort of the equitable access to just supportive care here. If you would, start with me in thinking about what are some of the opportunities we have from a health equity perspective to improve the care of patients for RP. Julie, can I ask you to go first?
Absolutely. So, I hear a lot of stories about RP patients going into healthcare settings and directions being given where they say, follow me, or stand over here, or there's only paper forms, not electronic versions. The signage is small and insufficient. The lighting is not adequate. And this occurs even in retina specialist office and ophthalmologist office. And so I think, hearing those stories illuminate for me the need, across the board, but definitely, too, in the eye care space, about how we can make services just a little bit easier, more accessible, and comfortable for people who have vision loss, who have RP. So those are the big things that I think about. There's also, electronic health records too being inaccessible for a lot of visually impaired. But I'll stop there. Those are the first things that come to mind.
That's perfect. And I really appreciate thinking beyond just, again, the access to this therapy that we're talking about today, because our report has the ability to get the attention of those who might have some responsibility for improving things like the signage and the directions and how we communicate. So that's great. Todd, I know you guys think about this a lot. What would you add?
Yes, I think the most salient point for us has to do with the confirmatory diagnostic test that's required to be sure someone has a genetically based condition called RP. There was a study conducted by University of Michigan a few years ago on the back of registry that we run, a cost-free genetic testing study, and they found that Black and African American patients were much less likely than their white counterparts to say yes to a genetic test, even if it were offered without cost. So that they found actually in this program evaluation study that when offered at no cost, those individuals who were Black or African American were more likely to take it up, but they were much less likely than their white counterparts to say yes before and after the introduction of a cost-free opportunity. So I think that still is a barrier, and understanding it remains a challenge, I think, medically for all of us.
Thank you, Todd. I appreciate that. Samar, please go ahead.
Yeah, I would like to concur there, but I want to make 2-3 points. One is about the care of guide dogs or things of that nature. When we interacted several patients, those usual care we think is a usual care, but if a guide dog looks at a squirrel and turn the direction, this patient lost its direction to go to home and was lost and don't know how to call now his daughter or her daughter. Same thing, there was issues we have seen in Uber, they cannot go with a guide dog that we saw in San Francisco area. So what we we normal vision individuals, things are very usual. There is a usual care. There really no care. As Dr. Mahajan was saying, we are comparing to usual care, but actually there is nothing for these patients. And most importantly, the patient population, advanced degeneration we are talking about, when they have less light perception, they not only impair vision, but also their psychiatric, because we know our circadian rhythm is controlled by light sensation through the eye. So a lot of these patients have unnatural sleep-awake cycles and related diseases, psychological disorders. So it's a greater value, I think, to patients give this vision. That's I think that's important.
I appreciate those points. Then we're going to weave some of that into how we think about the care journey for patients for this therapy, if it gets approved, and all the things that we all have responsibility for ensuring that that goes well. So excellent points. I appreciate that. Come on, please go right ahead.
Thank you. So you mentioned equity, Sarah, and when we think of it from the payer standpoint, health equity, like we as a plan care for patients who are sort of in all different socioeconomic status. We have the commercial population, we have the Medicaid population, the Medicare population. And I think one thing that we try to do is whenever creating policy or even looking at investigating a new gene therapy or drug is, what is the patient experience been? Because somebody who has the socioeconomic sort of availability to them in terms of they can get all these resources in terms of transportation and guide dogs and whatnot, as opposed to someone who is a Medicaid member who might be living in like some congested, compact housing without like even proper ability to like move around their apartment, things like that. I think those are things that are definitely there in the back of our mind. But then when policy is made, we have to make sure everything is accounted for. There should be no criteria that leaves out one type of population as opposed to the other. I'm not saying that, yes, we do everything for the bare minimum person or for the maximum. It has to be sort of a good blend of everything there.
And that's exactly what we're trying to elucidate. And let's keep that theme throughout today. And this is another opportunity. So I'm going to change my rules already. You don't have to wait till the end to tell someone that you want them to do better on something, or you think that's their responsibility or shared responsibility for addressing something like ensuring that the coverage policy or whatever policies we have in place are addressing multiple types of circumstances so that we're not thinking of it only in one way. So I really appreciate that. Lindsay, from your perspective, just thinking about this health equity question, what are you thinking about whether it's the accessibility of a therapy, the coverage policy piece, the usual care, anything you want to add on the health equity piece for us?
Yeah, so Sarah, I would just reiterate what was just said, but I think from like a payer's perspective, right? Like payers want to cover these drugs and they want to make sure they're covering them in a population where it's going to work. So they have to be accessible in order to work, right? So at the end of the day, thinking the same thing, we have to ensure accessibility and that it's going to be the efficacy and then will be achievable in those populations as well.
And we're going to get to that too. We're going to talk about the right patient for this drug, because I think that's going to potentially, I'm always a hopeful person, I'm optimistic, maybe de-escalate some of what we've seen in the gene therapy space where prices and access might be misaligned, and we're not talking about how to ensure the appropriate patient is getting it at an appropriate price. And so that's going to be a big theme today. Before we move away from equity, I want to go to our clinical experts. Dr. Mahajan, you've talked about this. You've sort of throughout the day in terms of your patients that come to you come from many different backgrounds. Do you have a couple of things at the top of your mind that you think we can be doing better from equitable access perspective?
Well, I think equitable access is probably the same across multiple fields of medicine. In terms of healthcare and, what kind of healthcare do you have? What kind of access to doctors you have? You can be in a rural setting and it's a long distance to travel, or you can be in a city setting and it's still a long distance to travel. And I've been in hospital settings where they do a pretty good job of that, and other places where they do a poor job. So in some ways, it's the same issue, whatever you're talking about. What is different with this group of patients is really the mobility issue. And I think you can imagine a person who's maybe wheelchair bound and can't get to the healthcare facility, and I think Julie was bringing that up a little bit earlier, where a certain treatment could be impactful, where somebody doesn't have access to ongoing support, things like that. So I think many of the things are the same. But with visual impairment, there are some key important differences to consider.
I appreciate that. And then Dr. Russell, what would you like to add here?
Don't really have a lot to add. I thought the comment made earlier regarding the difference between no light perception and light perception is very, very important. In fact, that's probably one of the biggest switches in visual function that patients can appreciate, because once they can orient to day-night, it allows them to maintain their circadian rhythm, and they really have a lot of sleep difficulties and other problems related to that. So, it's challenging sometimes to put the metrics that you get from these types of advanced RP trials in perspective, and to appreciate that many of these patients are just looking to have, to maintain some orientation to light and not to have loss. And, to have a gain is actually quite remarkable in this setting. So even when a small proportion, or in this case, a significant proportion of the patients appreciate what would be considered a very significant clinical improvement of 3 lines, or 0.3 logmar, that's a really substantial improvement. And so it gets buried, I think, in that concept of how far away from 2020 we are. But in terms of function, that's a big step in terms of improvement.
Thank you. And one of the things that I appreciate, oh, please, was there someone else?
I'll just say,
please, go right ahead.
Yeah, I think that was really well said, Steve. And I know there's some data that I don't think was presented. I'm not sure where it is exactly, but the patient questionnaire, like in the National Eye Institute, there's a visual function questionnaire. There's also a Michigan Retinal Degeneration questionnaire. This is a PRO, patient response. And I think that's really important for these kinds of studies. We saw what are sort of objective attempts at objective measurements, but capturing the patient experience is probably more important here than, let's say, a hypertension trial or a cholesterol trial, where you can capture exactly what Steve was just describing.
I really appreciate that point. And it's as if you had already seen my notes, because I do definitely want to touch on the patient-centered outcomes, the patient-reported outcomes piece, and also tie this to some of the experience we've had in previous reviews. And what can get lost, and we acknowledge this, even though we're the ones doing the research, when you average things over a population and you try to look for where the benefit is that there are times when what seemingly small change to those of us from the outside can actually make an incredible difference for patients. I remember an example when we were looking at Duchenne muscular dystrophy, the ability to keep using your hand to use your wheelchair yourself was incredibly important. And when you lost that, you lost a huge amount of your autonomy. That's going to be hard to capture in a cost effectiveness model. We'll say that out loud, but that's one of those contextual considerations that are so important as we think about evidence-based coverage policies, the fair pricing piece. Anyway, I'm just really excited you all brought that up, because that difference between light perception and not light perception is important for us to highlight here in our policy recommendations, that is clinically meaningful. So we'll have we're going to return to PROs. Before we leave health equity, I just wanted to double click on something that we've touched on just a little bit. Also reminding me of a previous review we did on COPD, where we actually heard from the patient advocates about how much trouble they have just getting the right oxygen tank from their health plan. And can we please just highlight that? Is there anything that this group wants to mention in terms of, is there something that could be done better on the coverage policy side for mobility aids, they're not covered now. Like, how can we make even the part of the experience of having a decrease in your vision better for patients with RP? Again, sort of separate from the gene therapy. Anything you want to kind of call out there as an equity issue? Access to mobility aids, dogs, etc.
I'll just say,
Dr. Macho, go.
you know, as a retinal surgeon, we're really good at diagnosing the disease, and then we're good at treating the disease with medicines and surgeries when we can. And if it's not a medicine or surgery, we're not great at helping the patient otherwise. And so we really depend on, sometimes it's optometry, sometimes it's low vision centers. And a lot of times patients aren't even aware that they have access to that. So as physicians, we can do a little, I hear this from the patients all the time. They're like, hey, you know, we come say the doctor and they don't say there's anything they can do. I say, well, have you ever seen a low vision specialist? And they'll say, no, I didn't even know that exists. Also for their children, for example. So making that accessible and that awareness is, I think, really important. That some of the physicians, the surgeons, you know, gene therapy, high-tech stuff is not going to solve.
I love that as a great recommendation that we can make, sort of identifying and help educate about the availability of low vision centers, just as something that we can do. And Hemant and Lindsay, we can think about whether it can be in a coverage policy, it can be part of patient communication. I think that's a shared responsibility that we can have. Todd, I might have seen you unmute on this question.
I was just going to second all that. I've heard from many people with advanced RP to say that low vision rehabilitation was huge for them in much the same way that adopting a white cane or service dog was for others. I mean, it seemed to be relatively low-hanging fruit, as they say.
Right. Awesome. And Julie.
I would just underscore that it's the vision rehab centers are not necessarily known by patients, by doctors. So if there's some standardization that needs to happen among, you know, physicians, just knowing, you know, to refer there, knowing what the resources are, but then also on the part of patients, you know, knowing that these exist and then, you know, being able to partake in the services. But by and large, what I hear is that there's just not enough access to assistive devices at the right time when they really need it, so people can go years without any kind of, you know, they might go to several different appointments and then finally hear about vision rehab, but they still might not qualify and they might not be able to afford an assistive device that could really help them.
Fantastic. Thank you. Hemant, I was going to put you on the spot a little bit about sort of where you see potentially the role of a plan here and you know, elevating the idea that low vision centers and low vision rehabilitation is a thing and that there's mobility aids, but please go right ahead and you can ignore that. But if you have
no, I mean, this is all what you just mentioned, what Julie mentioned actually. And I was going to, you know, say that when vision rehab is not something that pops into mind when you hear rehab. You know, people think of physical therapy, OT, you know, all those things. And vision rehab might be very important for somebody who is visually challenged and impaired. So the question that I have in this context is, when we hear rehab, rehab is meant to improve function, right? So does vision rehab in this context aim to maintain function, slow progression, or, which I don't think is possible, you know, given the gene issue here, or is this, we are saying that, listen, after administration of this gene therapy, you will need vision rehab along with it to get you the optimal sort of, you know, vision at the time. Because if that is the case, then subsequent vision rehab could become part of the coverage, you know, package.
Right.
If they get approved for this gene therapy, they get
Right.
X number of vision rehab, you know, therapy treatments and stuff like that too. So yeah.
I want to hear expert reaction to that, but I'm understanding this as this is just one of the things we could do better for the treatment of RP generally, is making sure that patients know there are vision rehab services available to help, regardless of whether or not they're getting the gene therapy. But let me just see if others want to comment on, do we think we need vision rehabilitation services after gene therapy, maybe for patients who hadn't received them previously? Dr. Russell, what are you thinking?
So I just want to point out, so the number of visual rehabilitation centers there are in the US is a very small number. And the reason is because it's often a labor of love for the people who do it. It makes a lot less money for an optometrist to run a low vision service than it does to prescribe glasses. I know that this may come as a surprise to this committee, but in 1972, we passed the point where a pair of glasses cost more than the reimbursement to a cataract surgeon to remove cataract. So just be aware that the finances can drive these things tremendously. So what that means is, for somebody to prescribe a low vision device compared to, say, being out and prescribing a few pairs of glasses in an afternoon, they can make a lot more money doing that based upon the coverage and the insurance programs that are currently being offered. The second thing I would say is that there is a unique distinction in medical coverage between vision and dentistry and the rest of medicine.
Yeah.
What do I mean by that? I mean that since glasses for normal people are considered non-medical, there is no typically any medical coverage for that. And that often extends to low vision magnification devices for these low vision patients. And also for their evaluations, because they're not considered medical, they're considered rehabilitation, which is not covered in the same way. And just to even extend it more from a governmental standpoint, for instance, it's very challenging and it's actually been legislated in my state, that a ophthalmologist cannot give a patient access to a handicap parking spot for mobility reasons, whereas an orthopedic surgeon, if a person has a limp, can get access to a similar parking spot. So there are very deep and distinct restrictions that are currently exist that, in a sense, affect the equity of application to visually impaired patients compared to other impaired patients.
I really appreciate that point. I want to, so we could end right now. Thank you all very much for being here. No, but when we have moments where we connect the dots on the fragmented way that we're getting care, the fragmented way we're insuring things, whether or not you have vision insurance or, I love the dental example, the reimbursement and how that drives behavior. You're making more prescribing glasses than you are helping with low vision aids. These are things that we can highlight as opportunities to reframe and redirect some of the incentives to things that are going to be high value for this population. So that was an excellent point.
Yeah, and if I can,
yes,
Sarah,
Samar,
add,
and then we'll go Dr. Mahajan. Please go right ahead.
Yeah, as Dr. Hora was mentioning, just to clarify about rehabilitation of these patients, the advanced RP patients not only having a genetic mutation, but they're lacking the photoreceptor layer. That means just by rehabilitation, they cannot see again, like Dr. Russell was saying, and that seeing is related to sleep and other psychological effects. So that rehabilitation cannot work. The low vision magnifier works when you have some vision left and you can magnify and focus on the other areas. So I just wanted to clarify that. And from the equity perspective, I know we may discuss this later, but our gene therapy being mutation agnostic, even the barrier for diagnosing the disease, and there are 40% of this genetic mutation which are not known, but there is a very good clinical diagnosis of RP exists. So we had an employee who was very well PhD from Caltech, could not identify the genetic mutation, but looking forward to such treatment because I think we are democratizing through this mutation agnostic approach. These barriers are being removed, that, okay, you have to have this mutation, you have to have the photoreceptor cells left, you have to have certain level of neutralizing antibody. Our trial was the most broad trial. We had multiple dozens of mutation and neutralizing antibody was not screened. There are variety level of neutralizing antibody to AAV, and so very heterogeneous population that was included in the trial. Sorry, I don't want to
Absolutely.
take
We're
more
going to
time.
get to the agnostic piece because I think that's so interesting. And it's a first time in the gene therapy space we're going to have. So we're definitely going to get to that. We're going to shift in just a minute, but Dr. Mahajan, please.
I'll be quick. This is a follow-on from what Dr. Hora said about and I'm not a policymaker by any stretch, but the idea that vision rehabilitation following this kind of therapy, and I would bet that, as Steve mentions, this transition from light perception to, being able to see something, and in some of the patients where they really moved from this no light perception forward, if you then added vision rehabilitation, you're going to get a double bang for your buck there.
Okay. All right.
The trial's not designed that way, but pairing those things, especially when patients are coming to be involved in, sophisticated high-flying therapy, is an opportunity to bring them into vision rehabilitation, and I think you'll get a significant boost.
Fantastic.
I do have a
Yes.
quick,
Come on,
I'm sorry,
please.
just
No, go right
a
ahead.
quick follow-up based on that, because I heard you mention, or somebody was saying, that there's no widespread access to these vision rehab centers, very few of them, maybe in the nation. Has there been any sort of assessment of any virtual rehab possible? Because I know there are innovative companies coming out there doing cardiac rehab, post-surgical rehab virtually at this point in time now. So I'm just wondering if that is something to keep in the back of our mind as well.
We can put that in there. Opportunities for an accessible virtual option. We'll make sure we emphasize that. We don't want to make it so it's not accessible, but I think that's a great idea to add as to one of our policy recommendations. Great. Let's shift now. I wanted to give this group an opportunity to just reflect on some of the votes we heard today, both on the comparative clinical effectiveness, as well as those benefits beyond health, special ethical priorities. I'm going to review quickly what we heard today from the CEPAC voting, especially for those who weren't able to be with us today. We heard that on the question of net health benefit, somperedogene, 10 yes, 2 no. So the majority of our New England CEPAC found the evidence was adequate to say that this new therapy represents a net health benefit for patients. On the benefits beyond health and the special ethical priorities, overwhelming support that there's a significant unmet need in this population. That was an easy one. That was unanimous. Racial ethnic group, a little all over the place in terms of the health equity piece. I think people were understanding some of the equity issues that exist for this population in terms of the getting access to assistive technologies and the low vision services. So that one was a little spread all over the place. Also strong support for caregiver impact potentially being another benefit here, and something we want to consider as a benefit beyond what we were measuring in our cost effectiveness model. And then finally, improved access because of the mechanism of action. Also more on the, yes, agree that this is an important part of the consideration of the value for this therapy. For those who were with us all day, or even those just reacting, anything that you want us to have in our heads as we're thinking about putting those votes in context as we write them up in our report, anything that surprised you from some of those votes today that you wanted to offer a different perspective on? Okay, not to have an answer here. If you were happy and expected all of the votes you saw, that's also okay in terms of how we'll write these up today. Okay. That's great. Then let's start talking about how we make policy around this. So we've got new therapy potentially being approved this year. We acknowledge significant unmet need in this population. We also heard today questions, durability of effect, the right patient population. So let's start talking about some of the specifics that will help drive a coverage policy that's based on the evidence as we have it now. I'm going to start with the clinical experts to react to this, but everyone's going to have a chance to kind of react to this. All right, Dr. Russell, who's the right patient for this drug?
So, to a certain degree, we have to abide by the entry criteria of the trial, which is counting fingers or worse. it didn't appear, for instance, that patients, so there were some patients that it appeared that were in the counting fingers range. It's hard to tell from that graph that we looked at, you know, that fine detail of classification, but it didn't appear that there was a huge difference between the no light perception. Some of the no light perceptions improved in a significant way as well, and some of the others didn't. So I don't think that you can necessarily classify. I guess the big concern on my part is that because of the mechanism of this particular gene therapy, meaning that it sensitizes the interretinal neurons, that actually, if I could mix my metaphors, speaks a different language than the photoreceptors send up to them. There may be crosstalk that may actually interfere with the interpretation of the signal by the occipital cortex. So my concern would be that you would need to use this at such an advanced stage that the patient actually had a depletion of their photoreceptors. You wouldn't want to use this, for instance, at an early stage of disease, but that still offers a potential intervention to those who have the worst forms of every genotype, which is actually the one population which is not eligible for any disease-specific gene therapy. So, you know, I can see scenarios here, for instance, where simultaneous with the development of disease-specific gene therapies, you have these agnostic therapies that can be utilized in situations where you don't have a target for conventional disease-specific gene therapy kinds of treatments. Really the only competing therapy concept that I'm aware of for this particular type of approach would be photoreceptor transplantation, which is also advancing, but certainly is not at this degree of development yet.
Okay. Dr. Russell and Dr. Myers, I'm going to go to you. I see you, Samar. Just give me 1 minute. Is it easy to know who has advanced RP? Do the payers need to hear like how to do this, or is this pretty standard practice to be able to know that someone has advanced RP?
Are you asking me or are you asking
Yeah,
Gina?
I would love Dr. Russell, just a reaction to that.
Okay.
That's a pretty straightforward. Yeah, go ahead.
So these are clinically defined characteristics. They're not
Great.
genetically defined characteristics. So they're things that could be assessed in an ophthalmologist's office. And I mean, typically when we start, so that the early changes in retinitis pigmentosa are not difficulty seeing in the dark, nyctalopia, and constriction of the visual field. Or narrowing of the visual field. So those are the earlier changes. When you start to see central visual loss, and you can do a structural test called an OCT. You can determine whether there is significant central photoreceptor loss. That between just a couple of quick, or I shouldn't say quick, between a couple of clinical tests, you can usually determine whether they're at an advanced stage or not.
Any ophthalmologist or retinal specialists only?
Go ahead,
Dr. Rajan, you can jump in. Yeah.
So he can take a breath. I agree with everything that Steve has said. At the earliest stages of RP, when you have a child or even a young adult coming in, it can be challenging, and you're looking at gene testing. But at the late stages of the disease, they are typically diagnosed in a non-specialist office. So an ophthalmologist can say, hey, this is advanced RP, by looking inside the eye, by taking an OCT, which is a common instrument to take a picture of the retina and its appearance, and from the patient history, and then those symptoms that Steve mentioned. And it's frequently diagnosed in the optometry office as well, and then referred to a retina specialist. So this is not something that really the initial diagnosis, it's pretty clear.
Right.
You
Great.
you
Please
asked,
keep going. Yeah,
yeah,
no,
yeah.
please keep going. Like,
You
who's the right patient? Yeah, then I'll go to
So
the next one.
who's the right patient? And I think Steve said it. It's based on the clinical trial. We're going to choose those entry criteria. This is a population of patients that you have nothing to offer when they come to clinic, and so they may start seeing you every 2 years or 4 years or 5 years because it's sort of a lost cause. And so you're finding the patients that have really bad vision. They're never going to qualify for a gene therapy trial. As Steve mentioned, they need photoreceptors. This is a very hard technology to box. I think the real competitor is the chip that we put under surgically. We have to cut the retina, slide a photosensitive chip. They have to wear glasses that shine a very bright, intense light. That's really the only therapy out there that's for these patients right now, 1,000,000 times more complicated than an intravitreal injection. We call it optogenetics, but this is very different. I know the earlier trials of optogenetics where patients were just targeting retinal ganglion cells. They were just seeing streaks of light, and that was bad. We say gene therapy, but a lot of times when we're saying gene therapy, we're thinking of gene replacement therapy for a recessive disease. The only thing gene therapy here is we're using a vector, a gene to deliver that protein. So it's almost like it's very hard to put this technology in a box in the context of what's been done. But I think that the patients to diagnose and whose entry based on this is pretty straightforward.
Right.
Maybe in the future, we're going to move that a little bit closer to the patients whose vision is not so severe. But it's not going to move all the way to a young patient where the exact gene, they have central vision, and they have some level of function.
That's great. Thank you. Samari, you've been very patient. Thank you so much. You want to react to some of that?
Yeah, definitely. I want to add some clinical and preclinical evidence on which patients will be best. So first of all, as we talked about, is 27 patients, but overall we have experience on 35 patients where we have seen when the patients are, of course, they're all advanced, but when their retina is thicker, then the visual acuity gains were more. 2/3 of the patients who were above the floor, they improved in visual acuity. That being said, visual acuity is not the only major outcome. So the patients who had very thinner retina in much advanced stage improved in light sensitivity, mobility, or shape discrimination. And that being said, our initial target for level is towards advanced RP with 20/800 or worse vision as in the clinical trial. But we actually experienced the improvement in patients, same as Dr. Russell. We had concern if there are leftover photoreceptor or out even inner segment, will that interfere the signal by targeting the bipolar cell? So 2 things I want to say. By targeting bipolar cells, we are very close to photoreceptor instead of ganglion cell. So it's utilizing most of the inner circuitry for signal processing. So that's why we are not requiring maybe much of rehabilitation need after treatment, but it is yet to be seen if rehabilitation will help there. But what is more important, both we have published literature, we as well as independent group has shown that when you target the inner retina, they can release, first of all, they were inactive. Now being active, they are preserving the structure of retina. We have seen this in mice as well as in NHPs, and other people have now reported. And also it secretes kind of neurotrophic factor that helps in stabilizing the bonding between ganglion cell and also can preserve the photoreceptor if they're remaining. So there are publications, multiple, not just from our group and other groups showing. So that yet to be seen in long term, how this is helping the remaining photoreceptor, how it's, but we have not seen any safety or confusion from the patients who are in better seeing. But our goal is now to address the high unmet need patients. That's what I wanted to talk.
That's great. That's great. And it saves a little of that too for future research needs. We want to hear where Nanoscope is thinking of doing additional research to answer some of these questions that came up through the day. Come on, thank you for waiting. Go right ahead.
Yep. So 2 quick things. And I apologize if this was done in the earlier part of the day. I missed the first hour, but maybe Dr. Mahajan, Dr. Russell can let me know. In terms of when we say, advanced RP as opposed to an early phase 1, is there variability in progression, or is there a pretty sort of steady, consistent path of progression? Like, members will or patients will worsen over, say, 2 years to 4 years when first diagnosed or whatnot, or is it just variable? Like somebody could go rapidly downhill as well. That's one thing, just to sort of consider the clinical piece of it. And the second thing, which I can also at the same time is more from the coverage of the policy standpoint, is when we said that an ophthalmologist could diagnose this, doesn't have to be a retina specialist. Is there a difference between who prescribes this gene therapy? Because that is one criteria that becomes a major criteria for, the policy where
One of my next
prescribed by
questions,
so and so.
Hemant, is who can prescribe this? But go right ahead. We're going to talk about that. Yeah, we can
Yeah,
throw that
so
out there.
that's because we hinted, that it could be diagnosed in an ophthalmologist's office. It doesn't have to be a retina specialist.
Right. But
So
who should
that-
be delivering this therapy?
right.
We were going to.
Well, that's the other piece. Who can diagnose and who will be delivering this
Yeah,
therapy?
the distinction there is really important. Dr. Russell, Dr. Mahajan, let's hear a little of your thoughts here.
Go ahead, Steve.
Okay, so this is partly opinion and partly insurance company driven from the experiences that I've had in working with Luxturna and so on. So we're currently at the stage where insurance companies have traditionally required demonstration of a gene-specific mutation to define the patient molecularly prior to demonstrating a willingness to pay these kinds of prices. And they want to be sure that this isn't some sort of unusual autoimmune disease that's causing a similar kind of pattern, or old traumatic disease that can sometimes look similar, or syphilis that can actually also mimic the disease. So the question then is, who feels comfortable performing an adequate, and that's another air quote, adequate genetic evaluation, because most of the commercial panels are not as complete as you might imagine. Let me just say, there have been studies that have looked at that. So, for instance, if somebody goes in and sees Venu and he performs prevention genetics panel, and then he says, yeah, but this patient clearly has the clinical pattern of Stargardt's disease, and I don't believe that they didn't find the ABCA4 mutation in the second allele. I'm going to go talk to my buddy, and we're going to look to see if there's another undescribed mutation somewhere else, outside of the coding region. So, and oftentimes we'll find them when we know that there is clinical evidence of that. So there's sort of a tier right now where a typical optometrist, ophthalmologist, general ophthalmologist, and even many retina specialists do not feel comfortable in identifying the genetic basis for the disease. And I think that's probably going to be the standard that's going to be required. So just to...
Well, can I drill on that real quick though? Since this
Sure.
is sort of like genetic cause agnostic, would it be reasonable to expect that the payer coverage does not require a genetic test to prove RP? Since it's advanced RP, we can diagnose that without a genetic test. Would that make things smoother on your end to not have to do the genetic test piece?
If you have sufficient data to demonstrate that it is truly gene agnostic, and then you
In terms of the therapy.
and then in the packaging or in the the label, it states that there's a certain genetic workup to exclude mimickers. So the answer to that would be yes.
Okay.
The actual administration of the agent
Yep.
is much simpler than
something
for
like
instance,
Luxturna.
Luxturna, which requires Venu or I to go in and
Yep.
inject under the retina. So
Yep.
this is something that general ophthalmologists do, as well as retina specialists in the US. So the actual administration of the drug is far, far, far easier than being sure that you have a correct diagnosis.
I understood. Thank you
This
so
is
much.
really
Dr.
good to
Mahajan,
hear,
please.
for policy making purposes too, because, when this does come on the market and we are making a coverage policy, we have our ophthalmology mass spec, as what we call, or the medical policy specialty advisory committee, where we have, ophthalmologists and retina specialists like you guys who will inform us the same thing. So it's good to hear different perspectives, even an ophthalmologist can instill this in the eye, so that's perfect for us to know. We can remove that requirement to begin with then.
That's great. Dr. Mahajan, please.
Yeah, so I agree with just about everything Steve said. And then Sarah, you mentioned, this is a clinical diagnosis. So somebody has to have advanced RP.
Right.
And then Steve said there's a handful of things you need to rule out. So you need to rule out there isn't a history of syphilis or trauma or autoimmune disease, which is typically done clinically. These patients, I don't believe, need to be gene sequenced. I mean, this is gene agnostic. Even if we sequence their genes, there's 40% of RP patients, we can't figure out what their gene is. But this is really, the way the clinical trial is designed, it's really a clinical diagnosis. They have to have a certain level of vision. There's a certain level of destruction of photoreceptors and things like that.
Right.
And I believe far into the future, we may, find that some of these other diseases that don't have photoreceptors, even though they're not, not from genetics, but the eye doesn't have photoreceptors, maybe from a trauma or retinal detachment or something, would be eligible for this kind of treatment for things. But I really think it's a good clinical diagnosis. Who's comfortable doing that? I'm a retina surgeon, so I always think only retina surgeons should be injecting these things for two reasons. One, our diagnosis is going to be better. I love to get the referrals from the general ophthalmologist and the optometrist, ruling out those other things. I think it's great if a retina doctor does it. We do 1 million of these injections, mostly from anti-VEGF. There are general ophthalmologists that are now doing anti-VEGF injections. And if a patient didn't have access to a retina specialist or something, maybe there's an argument to be made that a general ophthalmologist could be doing the injection if they had the sufficient training.
At the risk of spending more time on this one question, but this is one of my big ones. Given its genetic variation agnostic, but we saw a lot of heterogeneity in the treatment effect. Is there a research opportunity to be doing some sequencing to help understand which patients and which genetic mutations are more likely to respond?
So I'll jump in and start. So I love this question.
Okay.
The trial is really looking at patients who are degenerated. Nobody with a specific gene was excluded from the study, so they didn't say, oh, if you have this gene, we don't want to see you. And as Steve mentioned, there's 300 genes, and to cover all the genes, et cetera, that's never ever going to happen. Okay. What I believe is going to give us information on, which is the best patient or who's the best responder or super responder or a non-responder, I think is going to come from the biology. It could be coming from the imaging that we take. A lot of the other areas of ophthalmology are now using artificial intelligence to examine the images and make determinations of response and non-response in other clinical trials. And then my lab actually collects eye fluid, biopsies. We do liquid biopsies. We look at proteins. And so these are all sorts of different things of the biology that are independent of the gene. And it doesn't matter what gene they have. It's a question of how degenerated is it? How is there accelerated aging in the eye? Is there some signal on the OCT that's really telling us, hey, this patient has healthy bipolar cells or something like that? So I think the genetic sequencing is a lot less important, even though it may have impact for certain specific genes. Whether we can tease out that noise, I don't know, but that's my own futuristic
No,
opinion.
I want to hear Dr. Russell's reaction to that, and I want to say we made it 54 minutes before someone mentioned AI.
Yes. Sorry, my apologies.
No, maybe we should have aimed for sooner. Dr. Russell, anything that you want to mention on the sequencing? Then we're going to shift to some other questions.
So I alluded to this earlier in one of my comments in an earlier section about the data that we had from these 27 subjects that, we don't know yet. I mean, it hasn't been publicly disclosed to us what the actual genetic characteristics, what the mutations are. We might know something about some of the genes, but we don't know anything about the specific mutations within those genes. I mentioned 300 genes. That's only how many genes. That's not how many mutations there are in those genes. It's a huge number. And so, yeah, it's a huge number. So working things out from the genetic side is probably not going to happen in our lifetimes. But there are other considerations, and I mentioned one of those, which is the degree of degeneration of the retina if it gets past a certain threshold. And Dr. Excuse me if I mispronounced your name, Dr. Mohanty, is that correct?
Yes.
Yeah. So you alluded to the fact that it seemed that the patients that responded best were those that had the thickest retina. So that suggests that there may be non-photoreceptor degeneration that may be ongoing. So there may be some time limit in terms of degeneration. Now, when I say time limit, I have to be very careful here. There are some of these 300 genes that are affect the subject or the patient very, very early. For instance, I deal with a disease called CEP290 associated Leber's congenital amaurosis. That disease, patients are typically no light perception by age 18. So doing an adult study in a CEP290 population is almost impossible. And so, I'm talking relative ages and relative durations here, whereas a typical autosomal dominant retinitis pigmentosa patient may not, as one of the participants earlier mentioned, may not really realize it until they're in their mid-20s or sometimes, surprisingly, into their 50s or 60s before they're actually diagnosed. And by the time they reach the end stage that would be treatable with this approach, they may be, pretty advanced age, but that's the target population. So, it can happen in different age categories depending upon the severity of the disease in the particular subject. And so I think there's a much more likely opportunity to evaluate, for instance, having been in these studies before, you can go back sometimes and get permission from the IRB to go get other historical information about the study population and for instance, find out whether these patients, for instance, were ever cited. So they're such severe RPs that sometimes the patients are no light perception at such an early stage that they never had normal cortical development. Okay, so those patients really shouldn't be included in a study like this. Now, maybe they were already excluded. I don't know, but it doesn't say that anywhere in your report. So there is, for instance, some ways of trying to tease this out, looking at new populations, trying to establish what the duration is between, say, where they drop below 2200 and where they are at the time that they get treated. Those kinds of studies would be extremely revealing, I think, in terms of allowing us to dissect out this question from the other side, not the genetic side. That's a really complicated problem. Yeah. Or the third dimension would be what Vinu was talking about, which is look at proteomics, look at some other, functional factors of the retina aside from just imaging.
Great. So we're going to put that in the sort of future research needs sort of category, which is great. Samar, sorry, did you want to quickly respond to any of that? We were going to move on from.
Yeah,
okay.
So I think Dr. Russell rightly pointed out. So it's not just genetic. There are 300 genes, 8,000 mutations, And then, as you pointed out, we have patients which are 18-year-old to 85-year-old. So some gene may be very aggressive. So we did kind of do a AI modeling with limited data set to see because some of the gene impact the macula a lot. That's why you are seeing the variable outcome, because in certain genes impact the periphery more, the rod function, some are in the center, and depending on the age that the patient has been exposed to the disease. So these are all factors. So that we were trying to do some AI like Binu is saying, and try to see a correlation of them, because it's a much more complex problem, much more heterogeneous population, even in these 27 patients. And in spite of that variability, we had the statistical significance. That was amazing to us when you said, were you amazed by the outcome of the panelists voting in favor of it, but they have not seen the depth of the data, that how much variable these patients can be. In spite of that, in a small population, giving the statistical significance was the most surprising thing we thought as a company that we see.
All right, I want to try and do this a little more lightning fast. I want body language reactions. Sounds like we do not need a center of excellence approach for this. If we have ophthalmologists who can do this, okay, people are feeling, Lindsay, Matt, you hearing that? Okay, so that means I don't probably have to probe too much about sort of transportation to centers of excellence as being part of this. We think that a lot of RP patients, yes, some might be in rural settings, might be hard to get to their ophthalmologist, but if this is going to be in sort of regular-ish practice, anyone want to disagree with me here that transportation, we did talk about transportation a little bit earlier today.
So it's a good point. Patient transportation may not be needed. Rather, as a company, we want to remove the barrier, provide white glove service to deliver the drug on the day patients are coming to the clinic, so that same day they can be treated with the drug. If not treated, patient doesn't show up, the drug can come back. So we will be open to all those provisions so that it's easy to access these patients. And we have done a database of 75,000 RP patients. Of course, a very small fractions are eligible for treatment, but across the country, and there are some dense populations, but there are people who are not in dense big cities. So, and without requiring a subretinal injection, you are right, we can deliver, an ophthalmologist should be able to deliver it.
Okay, fantastic. Todd and Julie, anything that you want in the big brains of Hemant and Lindsay and their colleagues as they're thinking about coverage policy here to make the coverage policy as patient-centered as possible? So we've heard we're not thinking about centers of excellence. Ophthalmologists potentially are okay to do this, except if you live in Northern California, go see Dr. Mahajan because he's excited to do this for you. And then if there's anything that you want in their heads as they're thinking about coverage policy from sort of patient. Cost sharing, not a thing. This is a gene therapy. I don't think that makes a lot of sense. It's not going to like drive the decision making. So maybe no cost sharing. Julie, Todd, anything you want in their heads on the coverage policy side? Julie, go ahead.
Well, the first thing that comes to mind now, I'm not sure that this is fits right in this category, but I'm thinking about the mental health impact of being potentially in a sham, in the sham group. And I don't know the answer to that, but I think that I'd like to just, bring up the topic as an important one for perhaps eligibility as part of that, if it's part of the screening, but, really assessing and probably the researchers can speak to this if it's part of protocols already about expectations that patients and caregivers might have about a certain treatment, and then the mental health impact of unmet expectations. So I just wanted to bring that up. Not sure if it falls into this category.
If I
Julie,
may clarify.
1 second, Samar, 1 second. I think that can be an important part of just the general education about the introduction of a new therapy. So we don't want to, sort of dash hope, raise hopes too high. We want to be able to manage expectations about who's the appropriate patient and what is the expected outcome. Because even on, what we talked about today, these aren't people who are going many lines on visual acuity. They're not going all the way to the top. And so we want to manage those expectations. We can definitely work that in. Smar, did you want to respond to that?
Yeah, no, I wanted to just clarify, Julie, that this is we are not talking about a SAM control study. It's about in the real world commercial setting. So there will be no SAM control. And those expectancy that you are saying they will be in SAM. I wanted to clarify that. This is about.
Sure, but just, I think
Thank you.
it's still really important of, it's not going to work for everyone. Right. I think that we know from the data. And so as we talk about as clinicians delivering care and counseling patients, as patient groups talking about the introduction of a new therapy, I think it's very reasonable to expect that we can have a clear communication of, this is not a cure for everyone. This is what you can expect potentially from this therapy. So Julie, I really appreciate that point, and we can just really work that through. Todd, anything you wanted to add there?
I don't have anything to add on this topic. Thank you.
Thank you. All right, we're getting home stretch, everybody. Doing great. We are going to talk now about outcomes-based contracts. And I'm going to sort of set this up a little bit because I want to get reactions from everyone here on the appropriateness or not of that. And then we're going to spend a few minutes on future research needs. And Julie and Todd, I want to start with you on future research needs. So I'm giving you a little heads up that you can start thinking about what you would like to see from additional research in this area to support patient-centered decision-making. So when I am out in the world talking about how we pay for cell and gene therapies, given that they often come with big price tags, and that's another thing we're going to get to, Samar, in a minute, as we want to hear how you're thinking about pricing, we often hear, well, I need an outcomes-based contract if I'm going to make that big of an investment, if I'm a payer or a purchaser. I want to know that I'm paying for something that's going to work. If it doesn't work, I want to be able to get some money back. And that's how I'm going to give affordable access to my members. And so that has been the standard approach that a lot of payers have taken for any gene therapy. I already see a few challenges here with that being the approach, but I want to pressure test that with all of you. The outcomes here are hard to measure. We've got the best corrected visual acuity. We have the 2 manufacturer-produced sort of outcomes measures. We have patients who are having a change in the logMAR from really bad to a little less bad. It's not a very big change to like sort of measure and say whether or not something's successful or not. Samar, I'm going to start with you. Have you, as a company, been thinking about outcomes-based contracts or warranties as a way to introduce this therapy? And how are you thinking about how they could be structured?
Yeah, we will be definitely open to discussing with payers. We are a little early. We are in BLA submission process, but we'll be open to outcome-based research. But as you rightly pointed out, and we saw in our trial data, because of the heterogeneity of patients, 40 or 50% patient improving in visual acuity, rest of the 50% improving in others. So all patients had some kind of gain, and those gains were the 2 light level that was discussed in Luxturna. We have seen there is a precedence if you can perform a task in 2 light level. These are log levels. So that definitely improves the patient's life. But incorporating a mobility assay to a clinic, every clinic in rural setting and others will be difficult, but definitely visual acuity and the SAP discrimination test, which are validated. By the way, this test we have validated through observational studies, separate independent studies. So that may be implemented, and we are open to discussing this with the payers.
Fantastic. Lindsay, I'm going to go to you. And you guys think about this a lot. The program that you have offering access to gene therapies, any reactions to whether or not this is going to feel right for an outcomes-based contract or other innovative contracting approach?
Yeah, no, that's a great question, Sarah. So at the end of the day, right, like I'm not in these negotiations, and we do have products where these therapies can be essentially added to programs. But once it's FDA approved is when the conversations will really start, and we're asking the same questions you are, right? Like, how would we define the outcome? So we're asking the same questions.
Okay. Hamand, what would you add to that in terms of how you're thinking about this?
I would say what Lindsay said is exactly how payers approach this, but in terms of just general gene therapy, if we were to talk about it, all of them, we look at value-based pricing and those contracts, because when the pricing is determined, eventually once FDA approves and the price point comes to the market, and we see that price tag, we hear that this is not just the product, this is not just the R&D, this is also sort of the societal, benefits, long-term future, the whole thing. And depending on how much functionality the patient is able to gain or regain, I think that affects all of that benefit. So I think value-based pricing is definitely in the play here in terms of, if somebody is able to get back to, what they were doing, or 80%, 70%, yes, much more benefit, pricing maybe seeming right, but somebody who doesn't get as better, or there's minimal function regain, maybe we can put on a gradient, sometimes we run percentages in terms of value-based, okay, 10%, 20%, 30% pricing offset and whatnot. So it's very specific to once the FDA, approval comes out and all those things.
Okay, thank you for that. Dr. Mahajan, Dr. Russell, you're seeing these patients. Is it easy for you to know who's getting better and who's not? Are we missing an opportunity to maybe do an outcomes-based contract based on benefit, or is this just tricky?
Steve, do you want to?
Pass is an okay answer. Don't worry.
Okay, Vino,
I
I'm
can
going
answer.
first on this one. Something new.
What do you think, Dr. Russell?
So my mind just went blank. No.
You think it's tricky?
I'll say, I think,
Go ahead,
no.
I don't know,
Oh.
Sarah, if this is the right time to introduce the PRO.
Let's do it.
And so I do think that Dr. Mohanty mentioned sort of the three tests: mobility, shape discrimination, visual acuity, and the idea, hey, 2 out of those 3 things improve, so there's a trend. I think there's a lot of value in listening to the patient, keeping in mind placebo effect, and some people are really optimistic, some people are really negative, no matter what you kind of do for them. But in that, I think patients will really tell you. And some of these patients we've had for a long time, they can't walk down the hall by themselves. In the trial, there's an anecdote and a couple videos I've seen. All of a sudden, for the first time in a decade, the patient's walking down the doctor's hall by themselves, and they're crying. And that's hard to ignore. And I remember some of that from the Luxturna trial patients. And so those patients, there's not a numerical graph for that. It may be in a PRO, but those things are quite obvious sometimes when they talk to you about their functionality, that you're not measuring on the light chart or something like that. And there's things like that across medicine.
There are. Dr. Russell, what are we going to add there?
As you were discussing this question, it flashed in my mind about your model that you're basically, when I hadn't seen the individual breakdown of patient data until you showed me that chart earlier, and there's clearly a bimodal distribution. You have, the super responders and the non-responders. And what I was wondering, so in the external trial, that wasn't what we found. We found exactly the opposite, which is 27 of the 29 subjects that we treated had significant improvement. So it was essentially an all or none phenomenon with a number needed to treat close to 1. This is the opposite. This is, a significant response, doesn't seem to be as graded as some of the other gene therapies that we've tested. And it seems to be yes or no.
But that's just for the visual acuity, Steve, that one chart.
I know there is the light perception.
That's the challenge.
Well, yes and no, but what I'm thinking here is in terms of sort of what the view from 40,000 feet is from the payers. So there was a similar kind of approach with Luxturna originally required, but that was discontinued because such a high percentage of the patients responded. But what does strike me is that if you were just looking at the actual responders, okay, so let's say you incorporated some system where you're going to have some sort of a give back if there's 25% give back or some percentage give back if the patient doesn't respond, that would significantly affect the value proposition of the cost of the drug, because now you've essentially lowered the cost of failure.
Right.
And so it seems to me, that the higher price might actually be justified, but that would be a modeling thing that you could potentially do with your model, is
Yeah.
figure out what that ratio might be.
Might be. And we'll have that in our interactive modeler platform where you can vary the durability of the effect and the responders, and you can see how that changes things. Okay, we're getting close to almost time to wrap up, but Smart, I am so appreciative, and we are also appreciative that Nanoscope is participating in this conversation today, that you've been partners throughout this review. You gave us data and confidence and patient level data so that we could do the best we could with the data that we have. But now is my turn to put you on the spot. How are you thinking about pricing? Are you going to price it to the ICER value-based price benchmark? What are you thinking?
I think ICER has done a great job, developing this model. I want to congratulate you and your team there, have incorporating every public input, including ours. So the only issue, I think we still believe it has to be durable according to mechanism of action, and you are giving a slider. That's great. People can see. On the pricing aspect, we want to have this drug available to every patient who qualifies or who can benefit according to us. So we would like to remove any barriers that price can put there. Of course, a little too early to disclose the pricing, but we are open to, as I mentioned, outcome-based pricing. We are open to revise the pricing as we go towards, we do more research and we show in better seeing patients, we expand the patient population, we go to more mass indication like Dr. Mahajan was saying, any retinal dystrophy, not genetic, even geographic atrophy, if you see our pipeline, can benefit, but it requires further clinical research. And at that point in time, we'll be open to revise and talk to the payers and see what is the budget impact and all those kind of things. So we want to make it available everywhere, not just US, outside as well.
I really appreciate it, Smart. Thank you for being here. Ahmad, did you have a quick response to that? And then I'm moving us on to research needs.
It's not a response to that, but I just was thinking, this is a key point, I think, because given how coverage happens, there's also self-insured plans, which are more and more now as opposed to the fully insured ones. The self-insured ones, if the employer sees a benefit, they would be sort of hands-on board with this thing. But if they see that they have, an employee who didn't benefit from it, or whatnot, I think that has to be because for them, it's a direct correlation, will this employee be of a benefit from me if their functional status improves or not, it's some of that as well. So I'm just thinking it's interesting where functionality improvement could also sort of then inform, some of these self-insured plans who can choose or not choose to
to cover any
for
gene
this therapy. Yeah.
Right, I know. Well, what I hear here and what I'm optimistic about is that the commitment to work on potentially innovative contracting solutions, the commitment to think about pricing from an evidence-based perspective, and then the commitment to additional data. I think that came through in our entire conversation today, that while we recognize for rare conditions, it's small trials, I think that we all still believe in producing evidence to help make the best decisions for patients and the system. So we're going to do 2 rounds of rapid fire to end here today. So the first question that everyone gets to answer is, what is your top priority for future research needs? What do you want to see happen in this space? What kind of data are you anxious to have? And then we'll end with our call to action. And I promised Julie and Todd they get to start this round. So Todd, what is your top request for a future research need here?
Yeah, I'd love to see a study that looks at long-term durability of effect to include a patient-reported outcome measure like the Michigan Retinal Degeneration Questionnaire.
Thank you for giving a specific example. We will put that in there, the Michigan one. Thank you so much. Julie, top research need.
I would agree with Todd, and I would add, I think, and this might be a sort of a, I'm not sure that it fits here, but really thinking about, the long-term sustainability of getting more patients, more diverse patients involved. And so even having, you know, the study participants somehow serve as like peer educators going forward to recruit, you know, to teach and to recruit, you know, and to really expand the diversity of the participants.
Love that recommendation. Thank you. Lindsay, what do you want to see from the research enterprise on this?
Yeah, so two things. One that somebody else had mentioned before, I would love to see which patients do the best with this therapy. And then two, I work for an organization where we have an independent P&T committee that will review this therapy upon approval. But it came out very clearly today that these patients like need additional support to like mental health, low vision centers. I would love to see some sort of study when you have that whole patient health. How does that really, you know, change costs in healthcare?
Great, Lindsay. Thank you. Don't worry, Smart. You don't have to write all of these down. We're going to write them down for you. So you have a whole list of things that you can bring back for future research needs. Hemant, you're next.
So before I state that, I have a quick question here. I know this is being designated as orphan drug fast track. Is that still accurate? And in terms of the approval pathway, is this still going to be on the accelerated approval pathway? Is that what the premise is? Because that's what I'm aware of. I'm not sure if something has changed. Just want to make sure my understanding is correct.
Yeah, I can take that question. Definitely, this disease qualify for accelerated approval pathway, but the kind of benefit that we have shown, I think that is a regulatory decision they have to take, whether it's a full or accelerated approval. But whether it's a full or accelerated approval, as a partner to answer some of these questions we have, we are committed to do another study, a post-approval study, of course, in either case, where we'll be looking out for what is the impact of both eye injection, better seeing patients, and things like that, and the patient-reported outcome, which FFB mentioned. So we want to partner with all the patients and advocacy group to further have patients, even if it's a full approval. We are committed to do that.
Thank you. So I think you just answered or stated what I was going to say, you know, a post-approval study, which will look at sort of other factors. I think that's what we will look for, definitely. And also outcomes which are objective and measurable, of course, you know, in terms of both primary outcomes and secondary outcomes.
Thank you. Dr. Mahajan, what do you want from the research agenda?
I love a lot of the things that have said, and I think I've reinforced earlier, post-approval phase 4 study where really we get the PROs. A lot of mouse studies don't translate well in medicine, but in the eye, the retinal degeneration mice translate quite well. My expectation is that the durability will be longer, that the mice is going to translate. And so even keeping the phase 1 patients, the phase 2, the phase 3 patients under observation to really test out this durability question. And then finally, some way to figure out who the great responders are so they definitely get treated, and figure out who the total non-responders are so that we don't have to treat them.
I love that. Thank you. Dr. Russell.
I would agree with what Dr. Mahajan said and the other comments that have been made. I have talked way too much already, so I'm just going to let it go.
Dr. Russell, not at all. Samara, anything you want to put on your own research agenda?
Yeah, I think two more things I want to talk about quickly is one is that we have partnered with Verana Data and with FFB. We look forward to further strengthening partnership where we are monitoring the 75,000 RP patients, which is almost 3/4 of the patients across last 10 years at a median of 4 years of seeing how the natural history is declining. Right. And as some patient mentioned, when they go to advance, how rapidly they are going. So that's one thing, one research natural history we are doing in a mutation agnostic manner, but having genetic information from FFB, the Retina Tracker program, will be very beneficial. But another one is to other retinal disease. Our research, as I mentioned, not only better seeing patients, but we have a program in Stargardt disease. So we want to see how this can impact other retinal disease. So whatever we learn from here and the price cost effectiveness, we should be able to both clinical and cost translate to other indications. So that's the research we'll be doing internally.
Love that. We are now at final call to action stage. And so we're going to reverse the order. Samar's going to go first. But if you had one thing you wanted to request of someone in the ecosystem that would serve affordable access for patients to this new therapy, what would it be?
I think
Samar?
remove the barrier for genetic testing so that this drug
Okay.
is available without requiring a genetic testing.
Love the specificity of that and the length. Perfect. Dr. Russell, you're next. Call to action.
I would advertise and increase visibility to low vision centers and the need to maintain and enhance them so that they are more geographically available to improve equity.
And would you entertain a friendly amendment so that the reimbursement is there as such to incentivize the development and sustaining the sustainability of them?
I agree. I think that that would be a necessary what would you call it? Leg of the stool in order to support that kind of process.
Perfect. Thank you. Dr. Mahajan.
You guys have said everything already, but I'm excited to see this applied to other retinal conditions where there's loss of photoreceptors that may or may not be genetic. I think it's very interesting to explore in pilot studies. So I hope the company keeps going in that regard.
Thank you so much. Hemant, call to action.
I have to go back to the value-based contracting piece. You know, if that is a plan that could be put in place, I think many more plans would be acceptable, including the self-insured members and whatnot. You'll just have much more, you know, buy-in with that.
Thank you. Lindsay.
Yeah, that's where my mind went as well. Like, how do we define outcomes better? Because it sounds like that's a challenge. So call to action would be to find outcomes in a challenging space.
Great. Julie.
I'm going to pick two. The call to action is the patient-reported outcomes, PRO, so inclusion of that, and then the vision rehab expansion, funding, sustainability.
Love that. Thank you so much. And Todd.
I've got a totally different take on this question. I would like to see the manufacturer and the healthcare plans make sure educational materials are accessible to low vision and blind, and especially at appropriate grade levels.
Love that. We will absolutely put that in our recommendations because I think that is something that we should be doing regardless. Todd, thank you. I am deeply grateful to all of you for spending, especially the handful of you who were here all day with us. Thank you for your time, your expertise, your perspective. I am optimistic that this is going to be an example where we can ensure affordable access to a new therapy. I think that we've got the right ideas, we've got the right energy and commitment to doing so. And for a patient population that we talked about today having significant unmet need, I think that it's incumbent upon all of us to make sure that we're all doing our part to make sure there's affordable access. So again, my deep gratitude to all of you for being with us today. Just a minute or two early, Jason, I am going to invite you to come on back to help lead some final reflections. Actually, I think I might have one slide. Oh, no, here we are. Perfect. Final reflections from the New England CEPAC as we head towards wrapping up today. Jason, over to you.
Thank you so much. And thank you all so much for a vigorous and engaging policy roundtable. So at the end, we turn back to the New England CEPAC and have us all, we're allowed to have one final comment, and it really can deal with any aspect of the reflections from the day. We've at times at least tried to limit to one sentence, but we have an extremely generous interpretation for what that one sentence can include, like with lots of semicolons, for example. So I'm just going to start going around the table just in the order that I have, starting with Dr. Austin Fracht.
Hi, thank you. And thank you to everyone for such a rich discussion. It was a very thoughtful and interesting in many ways. And the only thing I want to bring back or resurface at the end is I would like to see a little more scrutiny of the existing data. In particular, there was one patient who had quite a large response, and I'm quite curious to see what the the overall results would be if that patient's data were excluded, and just to see to what extent that's driving the average findings. Thank you.
Thank you, Austin. Megan Golden.
Yeah, thank you, everybody. I want to recognize the importance of this group, the ICER staff, the panel, and Nanoscopes engaging so constructively in this process for a rare disease, where it's often a challenge to get very well-designed clinical trials like this. And I think it will benefit all the different players, especially the patients in the long run.
Thank you so much. Rebecca Kirsch.
Thank you all. ICER, the team really prepared us so beautifully and thoughtfully for today's deliberations. And I want to channel what Julie Grutzmacher said in terms of the opportunity with future research, but also just considering the evidence as it evolves to use that peer lived experience expertise of people who are living with RP to help educate, but also think about the patient, to identify the patient-reported outcomes that matter most as we proceed forward in this really exciting area of therapeutic development. Thank you all.
Thank you. Steve, Dr. Kogan.
Thanks. I echo those remarks. Great job by the ICER team, and thanks to the experts, not only for your expertise, but also for dedicating your work to this important condition. You think about just blindness and how fundamentally disruptive to life, can only imagine. So, thanks for your work. Thanks for the perspective of the patients too. This is one topic where I wish we could have had a lot more time with the patients and maybe even a Q&A. So thanks for their perspective, and let's hope this is the start of an era of innovation in this space.
Thank you so much, Steve. Next is Don Kreis.
Thank you. I would like to say that as somebody whose family feels a direct personal engagement with the world of gene therapy in the context of orphan diseases, I would like to do something uncharacteristic and single out for expressions of praise and gratitude the pharmaceutical company whose work is in the spotlight today, Nanoscope. I really appreciated everything I heard Dr. Mohanty say on behalf of his company. Really pleased that he expressed a willingness to consider value-based pricing and taking the ICER analysis seriously as they figure out how to roll this product out once they get approved by the FDA. And I'm really pleased that he expressed a commitment that I share to making sure that every patient who can benefit from this kind of therapy has access to it when it becomes available. Thanks.
Thank you, Don. Julie, Dr. Coopers.
Thank you so much to the ICER team and to our experts today. This was great. I think this is such an innovative science behind what we're talking about today and the ability to make a difference. I really look forward to seeing the pricing information and then more information about the durability and the longevity of this treatment. So thank you.
Thank you, Julie. Tara, Dr. Lavelle.
Thanks, Jason. Yeah, thanks everyone. This was a great discussion. And I think a lot of the issues we talked about are going to come up more and more as we talk about more rare diseases and gene therapies and the uncertainty that we'll see in the results coming out of those studies. So I think this is, yeah, just a reflection of other things that we'll need to be thinking about. And just related to that, I think that, yeah, I really agree with a lot of people that said that, value-based agreements can be, really helpful in situations like this, although they're very hard to implement. It would be great to see, more progress in that area. So thank you all.
Thank you. Dr. Mitchell.
So I was struck early on in today's discussion by some of the things that we heard from our patient advocates which was that a lot of the interventions that they have been able to receive that they describe as truly life-changing for them and have enabled them to continue to live incredibly rich and productive lives. A lot of those things were, they were not molecules. They were supports. They were different kinds of, in some cases, devices, accommodations, education. And so as we think about the full spectrum of things that we have and that we can do as a healthcare system, I think this is, again, not to use my word as to apply here, but there's low-hanging fruit out there, and it's let's call attention to that as well.
Thank you, Aaron. Dr. O'Sullivan, Brian.
Yeah, thanks. This has been a really exciting day, and the science is just unbelievable. So it's really cool science, and I think we're all excited about that. I would say I want to second a little bit of what Don Kreis said about Nanoscope making an effort to make this available to everyone. I think I heard you say even outside of the United States, which has been an issue with some other gene therapies that have been, or therapies, expensive therapies for orphan diseases that have not been made available outside of the United States for reasons that I don't fully understand. But I appreciate you wanting to do that. I hope the science can actually be applied to people with other retinal diseases, not just RP. So thank you very much for all you're doing. And I want to get back to something earlier. I actually voted yes for the value of this, although I was devil's advocate in saying some no things. I actually voted yes. I think this has actually got a lot of potential and will be helpful for a lot of people. So thank you for all you're doing.
Thank you, Brian. Joe Porter.
Yeah, thanks everybody. This is really, really informative and enriching. My reflection is, I feel like this is one of those unique situations where we were having a discussion about a disease that has no usual care. And so we're really sort of talking about both novel therapy and newness to people who feel like they've suddenly got an option that they haven't had any options before. And I think there's some real value to that. I think Dawn has reminded us multiple times of thinking about how we value hope. And this feels like one of those places where that was really a big part of the discussion. So I appreciate that.
Thank you. Dr. Wadera, Rishi.
Yeah, this was just such a fantastic discussion, and the science is very, very cool. And I just want to thank the ICER team for preparing us so well. I thought the patients' perspectives were so illuminating and important, and very grateful that they took the time to speak with us, and really appreciate the clinical scientist expert perspectives too. And I think the part of the discussion I really enjoyed, just because I think we're going to be thinking about this more and more, is how we think through issues related to generalizability and heterogeneity in trials that focus on rare diseases.
Thank you. I think I'm the only one left, so I'll just finish by, I don't like to repeat, but I will repeat this. We are so grateful to the ICER research team for such an incredible work here, tremendous amount of rigor and time that went into this. Grateful to the patients that you spoke with throughout the development of the report, in addition to those here today, the patient advocates, the drug manufacturer who has engaged the research team throughout the process and participated today, including in the policy roundtable. We're grateful for all of that. I'm grateful for the opportunity to have spent the day with you. And I think going forward, I think I just pick up on the issue around methods and comparative effectiveness research. There's so many times in the history of medicine where therapeutic paradigm has, at first, you get really excited about something and it doesn't work, or it's not clear if it works, and then but that leads to other tweaks that may really kind of lead to transformative processes. But the incredible difficulty that we have in health policy is that the costs of healthcare are sort of knocking up against 20% of the whole United States economy. It's getting close. And so how we call balls and strikes on the efficacy and cost effectiveness of these therapies as they come to market, how we kind of continue that sense of hope for patients who need hope and who deserve hope, while also sustaining a healthcare delivery system that can accommodate the costs of these therapies is something that's going to be critically important going forward. Thank you all. and we will see you next time.
Thank you, everyone.
Thank you. Take care.
Thank you.
Thanks, everybody.